Hello, Athena Lamnisos here, the Chief Executive of the Eve Appeal, and really delighted to be speaking to you around the menopause in what is World Menopause. It seems like week, so much going on this week to highlight the number of issues around the menopause, which we know is a really central opportunity around gynecological cancers and women's health generally, to talk about our bodies, to talk about the issues of menopause and cancer and all of the things that go along with that. So, thank you for tuning in to Probably Nothing. As you know, we called it Probably Nothing because that's the way that so many calls or emails to our Ask Eve nurse service begin. It's probably nothing, but. And there's a big but that often comes in there. And one of those is around postmenopausal bleeding, which always needs to be checked out, which is something that our fantastic expert guest will also be speaking about today. So, to bring her in, I'd like to introduce Dr. Philippa Kaye, who is a GP and a passionate advocate around all things women's health, and has got her own story to tell around cancer and indeed the menopause. So, Philippa, what would be great is for you to introduce yourself and say a little bit around your kind of experience in this area, but around the menopause particularly, because we bandy around that word as though it's one thing, and we know that it's not. I mean, literally, it's not. And I think that people get very confused about those issues, certainly in our space where many people have been through cancer treatment.
Thank you for having me. So, first of all, I have to apologise to everybody. You can see my husband's comics behind me. We had a little, and I'm really dark. We had a few technical issues before we started, but we are here. So, my name is Dr. Philippa Kaye, and I am a GP, and I have a particular interest in women, children's, and sexual health. I am a bowel cancer patient myself. I was 39 years old when I was diagnosed with stage 2 bowel cancer, and I have had multiple surgeries and chemotherapy. But the reason that I started getting interested in the menopause was because I was seeing women every single week in my GP surgery who were struggling with symptoms, and they didn't necessarily even realize that they could be related to the menopause or the perimenopause, and didn't even know what it was. Because whilst we might have learned about the birds and the bees, they were probably called at school, and also we were learnt about sex and learnt about puberty, and we learnt how to conceive and how not to conceive. Nobody said anything about the menopause. And maybe you saw your parents arguing over the thermostat, or your mum hanging out of a window, at midnight going, "It's so hot," and that was it. And so this is a conversation that has to keep happening, because education and empowerment are what is required so that you can take control of your body. Now, the menopause is the Latin word for the last period. That's what it means. There's a medical word for your first one, that's called menarche. And don't ask me why it's all got men in the title, but it does. And it means your last period, and you can't say from a medical point of view that you've been through the menopause until you haven't bled for a year. But there are different kinds of menopause. So there is what we would consider to be and I put it in inverted commas, the natural menopause, and the average age for that of women in this country is 50-51. But you might have a premature menopause where it happens significantly earlier, and that often happens with regards to cancer patients. So you might have a surgical menopause if your ovaries have been removed. There might be a medical menopause where we have given a medication which has essentially stopped your ovaries working. Chemotherapy can do that. Radiotherapy can do that. So you might have entered that postmenopausal phase at a stage far younger than otherwise expected. One of the things that is really a common confusion is, how can I be menopausal if I still have periods? But just as puberty took you a few years and starting your periods was just one event in that, the perimenopause is generally the lead up to the menopause, when you can have symptoms irrespective of whether or not you have periods. But if you know, for example, that you're having a surgical menopause because you're going to have an oophorectomy, your ovaries are going to be removed, then there often isn't that lead up time, because one day you had them and they were working and the next day you don't. But the menopause essentially is a state where the ovaries aren't producing an egg every month anymore. There is no longer a menstrual cycle. And what that means is that the ovaries are no longer producing estrogen, progesterone, and women also have testosterone. And it is the lack of those hormones which leads to the symptoms that we classically ascribe to the menopause. And those can be physical as well as psychological symptoms.
Thank you very much. That was really helpful for putting, the kind of three different types of menopause, as it were, in context. Um, the surgical menopause is quite often something that, well, all sorts of people who've been through cancer treatment, but certainly the gynecological cancers, will ask questions around. And they'll also ask questions around other impacts around surgery on their fertility, on menopause, on what it means for them. Could you just give an overview of the kinds of things that particularly people who are affected by cancer, and indeed the gynecological cancers, so what they might have had removed, as well as the impact of radiation, other forms of treatment, chemotherapy, what might they have, and what might they need to bear in mind about the menopause? Because then we're talking about very young women quite often, and we've got a few questions coming later that are from very young women who you wouldn't, naturally, normally associate with menopause.
The first thing is that and I know this as a patient, that when you are in treatment phase, it's all about survival. What do I need to do to get through, right? And you don't think necessarily about what's going to happen next or later, because it's all about trying to survive now. And I think as doctors, we need to talk much more about the later and the forward plans for the later. Because often when you finish treatment, and I know from myself, when I finish treatment, suddenly you're like, okay, now what? So you've worked so hard to get essentially the rest of your life back, but nobody has really spoken about the impact of what you've had done might be on the rest of your life. And I think that we need to be much better at talking about that. The first thing is, what are the symptoms related to that lack of estrogen? And we need to think about this as a long-term estrogen deficiency state. So physical symptoms, hot flushes and sweats, joint pains, palpitations, headaches, dry itchy skin, that kind of thing. Loss of libido and insomnia, and I can put those at both physical and psychological, those last two. Psychological symptoms can be irritability, mood swings, depression, anxiety, loss of libido and insomnia go there as well. What we would call the menopausal brain fog, difficulties with memory and concentration. And if you think about these things, they have a real impact on life, right? This is your ability to work, your ability to function in all the roles that you do, your ability to have an active and good sex life. All of those things can be affected. And then in the longer term, there is a long-term issue with that estrogen deficiency, in that you might have recurrent urinary tract infections. Everything can be very dry in the vulva and the vagina, and that can make it more difficult to get aroused or reach orgasm. Sex might be more painful. And in the longer term, there's an increased risk of conditions like osteoporosis. And so we need to be sort of forward planning. When it comes to having a surgical menopause, we know that the ovaries have been removed and they are not going to start working again because they're not there. And in that situation, if you are under the age of 50, then there is no increased risk to starting HRT. You are hormone replacement therapy. You are simply replacing the hormones which would otherwise be there. And it's really strongly recommended that you do start HRT in that situation, because we want to decrease the risk of things like osteoporosis and cardiovascular disease in the future. If you have a medical menopause, if I've given you a medicine that might put you into the menopause, or give you menopause-like symptoms, if I've given you, and I'm using eye as the royal eye, given you radiotherapy, for example, if you're very young, I don't know, and by very young, I don't actually mean very young. I mean, if you are under the age of 50 and ordinarily you would have a menstrual cycle, I don't know if your menstrual cycle is going to come back. And that can be really difficult for people because there's a level of uncertainty of whether or not the state that you are in now is going to be the state that you are in forever. And there are also issues with regards to fertility and contraception. And that seems to be contradictory because you would say, well, why are you talking about fertility issues in one hand, but then telling me that I need to have contraception? And that's because your ovaries might start working again, or they might start working sort of very sporadically. And so there is a risk of pregnancy. And so often in that situation, actually, with premature menopause, which might have a medical reason, or even if we actually don't know what the reason for your premature menopause is that we would use something like the contraceptive pill, because the estrogen and progesterone part of it would act like HRT, but it would also protect you against pregnancy as well. And I think that these are issues that really, really need to be talked about because it's so confusing for so many women. And when it particularly comes to a surgical menopause, when the ovaries have been removed, lots of people will say to me, it just felt like I fell off the cliff, that the symptoms were particularly severe. And that's because you've gone from everything to nothing. With regards to your hormone levels, and there was no gradual fall off, or there was no sporadic increase and decrease in estrogen levels, which often can happen around the time of the perimenopause, in that you went from high levels to none, and so symptoms can be particularly severe and they require treatment, and it is something that your surgeon should be talking about straight away.
Mm-hmm. Thank you. And I think there is just so many issues there, and that's one of the reasons why menopause is actually a very good opportunity for communicating with women about changes in their bodies and about signs and symptoms. And as we know, I mean, any of the 5 gynecological cancers can affect you at any age, but the majority of people who are diagnosed are postmenopausal, but by no means none. But it's a very, not by no means all rather, but it's a very good opportunity for really getting to know your body. Now we've had some questions come in that are quite kind of specific to a lot of the issues that you've already talked about, Philippa. But just to answer them directly, and this is a question which we get an awful lot. I'm in surgical menopause after having had my ovaries removed due to ovarian cancer. I'm really struggling with menopausal symptoms. Will they get any better over time, or will it always be like this?
So, firstly, I'm sorry that you're having a hard time, and I think that it's important for people to acknowledge that. And I think that as doctors and as friends and family and everyone else, we always try to fix things, right? That's our instinct. How can I fix this? How can I make it better? And actually, often what we need as patients is to hear that's difficult, right? So I think that there's a number of things. Often women will say when they go through a surgical menopause, or even sort of the menopause which would naturally occur at about 50, that the symptoms are worse for the first few years, and then those short-term symptoms settle down. And so you might find that there's an improvement. However, when it comes to a surgical menopause, those symptoms are often really severe at the beginning. Just as I said, that you've gone from having everything in terms of estrogen and progesterone to having none. And especially if we are in a premature menopause because of surgery, we would really recommend HRT here. And HRT can be life changing. And I know that it's had a lot of bad press over the years. And it had some bad studies over the years. And the studies that we looked at for a while are not really what we do now. And so it's comparing apples and oranges. And you have to remember, if you went through surgical menopause under the age of 50, having HRT is simply replacing what would ordinarily be there. So there aren't increased risks. And so I would definitely say that it's important that you went and got help with your symptoms. Now, there will be some people who will be concerned, well, I've been told I have an estrogen receptor positive cancer. My cancer is responsive to estrogen. Therefore, I can't have estrogen in HRT. Now what? What can I do? And the answer to that is there's still lots. And it's still so important that you go and see your GP, because there are prescribable options which do not involve hormone. So we can use antidepressants and anti-seizure medicines, and that doesn't mean that I think that you're depressed or that you have epilepsy. It means that we use these medicines for lots of different things, and they can really help with symptoms. So don't think, well, if I can't have HRT, I can't have anything. And the other thing to say is that vaginal dryness and pain during sex are really common in related to the menopause. And having vaginal estrogen, where the estrogen goes directly into the vagina, isn't associated with any long-term risks at all. And that in itself can be life-changing for women who are just sort of sore and uncomfortable, or sex is really painful, or they're getting recurrent urinary tract infections. So what I would say is, if you are struggling, please go and see your doctor and ask for help.
Hmm. Thank you. That's really helpful. And actually, we had a question come in about if I have an estrogen positive cancer and I can't take HRT, is there anything I can do? So that's really good advice around estrogen that can be applied directly to the vagina, not increasing any risks. And generally, around allaying people's risks around their worries and concerns around HRT, would you say that the best place to start is your GP?
I think that the best place to, that's an interesting question, because I think the best place to start actually is yourself always. Because I love it when patients come to me with bits of paper or a book or something, because it means that you and I are on the same team. We are both about you taking control of your body and taking control of your health. And if you've got your information from somewhere which isn't evidence-based, then I will say that. And if you've got your information from somewhere that is evidence-based and it's not something that I'm aware of, then I will go and educate myself around that. So I think that empowerment is really important. And then I think you need to go and see your GP. And bearing in mind that you might have seen a surgeon, an oncologist, a clinical oncologist, and a medical oncologist, so one who deals with radiotherapy and one who deals with chemotherapy. And you might have seen lots of different people. You might have had more than one surgeon. You might have had a bowel surgeon and a gynaecologist. There might be lots of different people involved, and your GP is that central hub where all the information comes in. And in an ideal world, our job is to look after you holistically, in that we're looking at all of you. And so, first of all, we should be informed of everything that's going on. If you think that your GP is not the right person for you, then most GPs are in a group practice these days. They are not single-handed anymore. So you ask your receptionist, who is the person that has extra qualifications in women's health? Who is the person that sees women's health in the surgery? Because often there will be somebody that has an interest in it, and I would go and see that person. And then if they need help, they will write and speak to your oncologist, and that's okay. That's someone saying, you know what, I need a little bit more advice in this particular situation. So I think that your GP is a great port of call, but I think also we all need to be empowered for ourselves about what the options are as well.
Thank you. And we've got a few more questions that have come in, but it would be useful to come back at the end to sources of information, where to get information online. I mean, it's been very striking, the growth in kind of products and services around menopause, and all sorts of things have been popping into my inbox, and I'm sure into yours, selling a whole wealth of lotions, potions, and other things that may or may not be helpful, but I think that people are finding it quite baffling to kind of work their way through. So let's try and come back to that at the end. A very typical question that comes in from a younger person. So I'm menopausal after my cancer surgery. I'm 27 and I'm getting back on the dating scene. I'm anxious about how to deal with that and how to navigate sexual experiences as I've got vaginal dryness and I'm embarrassed, nervous of telling people about the menopause. And, have you got any tips? And I'd say what also often comes along with this is a question about fertility. How do I tell people that I am menopausal and I probably can't have children, or my fertility has been seriously compromised?
So I think that this person is incredibly brave to write a question that many, many people will be thinking, which is this huge thing happened in my life, and this huge thing is going to impact on my life going forward. But I haven't met my person yet. How do I tell my person? But maybe I met my person on Tinder and it's 2 dates, or on Hinge, or wherever you met them. And at which point do I tell them? And for every single person that will be different, and in different cultural groups that will be more difficult or less difficult, and these are difficult conversations to have. But in my professional opinion, and in my opinion as a person, honesty is always the answer. The question of when you have that conversation is potentially more difficult. Now, there are things that we can do to make things easier. So reduced libido or painful sex are really common, and especially after the menopause. And there are lots of reasons for a reduced libido, and we are complicated, complex beings as females. And if it was as simple as the little blue Viagra pill, a pharmaceutical company would have made that a long time ago. But estrogen definitely has an impact on your libido, as does testosterone. So HRT can help, and HRT with a little bit of testosterone can help. But if sex hurts, then your libido often goes down, because why would you want to have sex if sex hurts? And often it hurts because everything is very dry, and that is often a side effect of the menopause, but it can be a side effect of chemotherapy, and it can be a side effect of radiotherapy. And there can be structural changes in the vagina, which are due to surgery, but actually radiotherapy can do that as well. So first of all, good lube is the answer for sex, for lots of different reasons. Something that doesn't irritate the skin, and we are sold so many products as women which we either don't need or are actively harmful. So we need to be using products that don't harm. There are vaginal moisturizers, and there is vaginal estrogen, which for most people is suitable and safe. The fertility question is difficult, and it's difficult also because you might not know the answer yourself, and you might not know the answer because no one's told you the answer, because they don't know either. And so there's a difference between, for example, if you had your womb and your ovaries removed, then you cannot carry a child now. You cannot become pregnant. But if you manage to freeze some eggs or freeze some embryos, but you don't have a womb, you could potentially use a surrogate. If you manage to freeze some eggs and you have your womb, well, it's possible that those frozen eggs might be used in an IVF cycle, but that isn't a guarantee of success. If you've had surgery to your cervix, then yes, you might get pregnant, but it might be difficult to carry to term. And so there are so many, and those are just some of the options. And so there are so many unknowns. And I think that makes it really difficult. And I think that as a person, it makes it really difficult for you to process, because you can't grieve, or it's harder to grieve because you don't know. And I think that needs a lot of talking through, and it's something definitely that we need to talk much more about. And I hope that in whatever relationship you have, that you find somebody that is able to talk about these things, and that you can get the appropriate help if you need to. But as I said, we need to be talking far more about those long-term implications, because you could be 10 years down the line from your cancer treatment, and you might not think of yourself as a cancer patient anymore. But your life has still been changed by cancer, and it's going to be changed going forward. And that is something we need to take into consideration.
Thank you. I mean, there's almost a program of half an hour discussing that on its own, isn't there? Because there are so many different permutations, different things, a lot of unknowns actually in there as well, around fertility, cancer treatment, menopause, and where you are after that, and what advice you need. Two more questions. I have surgery soon to remove my ovaries, and I'm worried about what will happen. What should I expect, and how will it be? How bad will it be?
How bad will it be is a how long is a piece of string question, because actually, if you talk about the menopause that happens age 50 without surgery or medication, 4 out of 5 women will have some symptoms. That means that 20% of women don't have symptoms at all. So some people will not have symptoms, and other people will have very severe symptoms. And those symptoms, as we said, can really impact on your physical and mental health. When you have a surgical menopause, often those symptoms are particularly severe, especially at the beginning, because we've gone, as I said, from lots of hormones to no hormones. Plus, you're recovering from surgery. And that is, a process, and in itself doesn't necessarily make you feel brilliant. But as long as it's appropriate for you, in most situations, you would be started onto estrogen therapy, HRT, if they're removing your ovaries straight away. Sometimes it can vary, but in general that you're started quickly. And if you're started quickly, then hopefully your symptoms won't be too bad. Now, often we will start at a starting dose, but there's room to maneuver. So if your symptoms aren't controlled, don't think, well, I'm on HRT, I'm done now. HRT is not one size fits all. HRT often needs adjusting. And even if you go through a menopause at 50 or 54 or 48 or whatever, and you decide to go on HRT, often that dose will need adjusting too. And it might need adjusting over a period of years, and that's okay. My answer to this is, I don't know. I hope it's okay, and I hope that you get treatment. But if you are struggling and you don't think, I'm on treatment, I'm done now, please go and ask for advice.
Thank you. And the last question that's come in is one about memory loss. So, memory loss is something that people talk about, and sort of how am I struggling to concentrate is something that people often mention. And what we notice is that people are they become very kind of, I can't remember when my last period was, I can't remember when my symptoms started, which can be something that you suffer from at any point. One of the things that particularly gets asked is around, how that affects me at work. So, what will my employer think? Will they be understanding? And what's normal? What's normal memory loss or failure? Inability to concentrate as you used to as you get older, and how much of it is affected by the menopause.
I think this is really, really common, and what we would call the menopausal brain fog can really impact on women's lives, and also on their self-esteem and their mental health. Because your ability to function at work is important. And often people are then worried about going to talk to their line managers about a women's health issue, because there is still a big stigma and there are taboos around the menopause. In 2018, the Deputy Governor of the Bank of England called the economy menopausal. And when he said that, what he meant was it's stagnant and a bit flat, right? And he had to apologise, okay, but he used that word to sort of mean a bit past it, right? And that's what we are viewed as in society, that if you're menopausal, if you're past your ability to bear children, if your youth and your looks that are associated with youth, that's what women have been valued for millennia. And we grew up in that paternalistic society, and we are fighting to change it. But we also grew up in that, so we're affected by that. So these thoughts often link into our own self-esteem. We are trying to change it. There is a big campaign called Make Menopause Matter, which is trying to ensure that every workplace has a menopause protocol, for example, that people are informed so that we can have these conversations, and these conversations can become easier. I have to say, the combination of menopausal brain fog and chemo brain fog must be pretty hard. Plus fatigue, plus everything else that is going on. And that definitely can impact. And again, one, it doesn't mean that it's forever, but two, if you are struggling, ask for help.
Yeah, it's the double whammy. The double whammy of menopause brain fog and chemo brain fog is quite something. Thank you, Philippa. Really helpful kind of romp through the questions that have come in. I mean, you mentioned the fact about kind of helpful and unhelpful products, and it does sometimes feel as though, you know, our bodies really have been commodified from menstruation through to menopause now. And it's quite staggering what's come in just this week alone around the kinds of things that you can buy and where you can go for information and who's got something evidence-based and informative to say around the issues. Where are the particularly informative pieces of information, you know, information out there that you see as kind of really helpful to people thinking about these things? And what are the products, if not the products, because I'm sure you don't want to name specific products, but what are the things that people should be looking out for that could help them? And what should they be avoiding at all costs? Because I really think, again, this is something very confusing, whether it's vitamin pills or other kind of replacements. We've talked about hormone replacement, and you've talked a lot about, you know, lube being our friend, which, you know, but what should people be looking out for and avoiding, or looking out for and doing some research around and seeing if it might suit them?
This is a great question. And you have to stop me if I start ranting at you. Because women's health, women's bodies, the taboos around them have meant that we are a commodity, because if periods are dirty, they're not, but if periods are dirty, that's why we create feminine hygiene as opposed to feminine care, right? Because you're dirty, so you need to be clean. And that whole sort of idea has been moved into the menopausal space as well. What can you buy to fix you? Bearing in mind that we're really vulnerable, right? Because something huge is happening and we're so kind to teenagers. We let them sleep in and we excuse their grumpiness and we say, oh, they're going through puberty, and we are less kind to ourselves when we go through the menopause. But we have receptors for these hormones from the hair on our head to the skin on our toes. It affects every single part of our being. And when you're vulnerable, you want an answer. And so you think, well, is this supplement or is this treatment or is this cream or whatever the answer? The first thing to say is the only supplement in the UK which is recommended routinely is vitamin D in the winter months. But you may have a specific case that is different for you, but I am obviously talking generally here. I can't give specific personalised medical information. When it comes to where you go to for your research, we need to be looking for somewhere which is trustworthy and reliable and is evidence-based. The NHS website, the Patient UK website, Dr. Louise Newsom's website. She is a menopause doctor, and she's created actually a menopausal symptoms tracker app, which is free. Those kind of places we know are going to give you evidence-based. There are lots of books, I even wrote one, which are based in the evidence. When it comes to what to buy, I think what not to buy is just as important. So yes, I talked about lube, but the particular kind of lube actually matters, because if you are getting, for example, a very highly perfumed flavoured lubricant, that's likely to have something sugary in it. That's likely to change the pH balance of the vagina, what we call the osmolality, which is sort of, if you remember from biology, GCSE, osmosis, which is how water gets pulled in and out of cells. And all of those things can be affected by lubricants, which can then affect the natural microbiome in the vagina and make things worse, not better. So what to buy and what not to buy. What not to buy is really important. And so we'd want to buy stuff that has no irritants in it whatsoever, that's not going to make the situation worse. Particular brands for lubricants would be Silk or Yes, and they are often really good. We want to avoid putting anything in the vagina at all. Your vagina, bearing in mind, your vagina is that internal tube The vulva is the outside. The vagina is a self-cleaning tube. It's very clever. We leave it alone. And we don't put anything inside, and anything that we do is likely to irritate it. So what you buy and what you don't buy is really important. And if you are going to try a herbal supplement or something like that, please do check with your pharmacist that it doesn't interact with anything else that you are taking. The fact that something is herbal doesn't necessarily mean that it's safe, and I'm not anti any of those things. If they work for you, I just need to be sure that it's not going to cause harm by interacting with something else. But I think the overall message is, again, that this is something that you need to fix or you need to put up with, right? And actually neither of those things are true. It's about the impact on your life. And if you're saying, I need help, I'm done, please help, then I would say that your doctor is your first port of call. Yes, of course, there are lifestyle measures that we can all take which will help menopausal symptoms. We know exercise decreases hot flushes, even though it seems weird, and at the beginning they might seem to increase the flushes because you're getting hot as you exercise, but actually in the long term it decreases your flushes. Avoiding caffeine, eating well, all of these things. There are lots of lifestyle modifications that can help. And that doesn't necessarily mean that you have to go and buy a cream or a face cream because you are a woman and something is wrong. And that's not the case.
Yes, I think that's a very good point, a very, very good point. And people will be deluged with marketing materials at the moment, marketing the menopause. Thank you, Philippa. That's been fantastic. And I know that we'll continue to get lots of questions in, and hopefully you'll be able to come back and talk to us in more detail about some of the issues that we've only just scratched the surface of. I think before we say goodbye, it would be fantastic if you could just say one thing that you want people to be aware of this week, and everyone to be aware of about the menopause. What is it that really gets you going, and you think, if only people knew one thing, what would it be?
That's such a great question, and I'm going to use a little story. When I was doing the research for my book, The M Word, what I wanted to know was why the hell the menopause happens in the first place. And whilst I might know why it happens if I've removed your ovaries, but why does it happen in general? And there are loads of theories, and actually no one knows the actual answer, and it's probably just that we're living longer. But one of the things that I came across about was a story from the animal world, and it's some kind of locust grasshoppery type thing, and it has males and females. And whilst the females don't bleed, they're insects, they don't, they're not mammals, they don't have a period. But in this particular branch of insect, the females live in a postmenopausal state. They live in a post-reproductive state, shall we say. And when the colony of whatever kind of grasshopper is under attack, they send out their post-reproductive state females to defend the colony. Now, 100 years ago, you would have looked at that, and with the paternalistic view of society, you would have said, let's send in those females because they are past it. They are not of value anymore. So they can go out and defend the colony, doesn't matter. But actually, I think that we need to spin that on its head and say they send out those females because they are wise, because they are experienced, because they have the wisdom of having got that far in their lives. And if you are somebody with cancer, you have gained an awful lot of wisdom going through what you have gone through. And even if you haven't had cancer, you've got to the menopause or a premature menopause, and you have lived your life up to this point, and there is such a lot of value in what has happened to you and in what is going to happen in the future. And so we should be triumphing these women. Triumphing is not a word, but we should be celebrating these women for the wisdom they have, so that they can take that and live the rest of their lives happy and healthy and safe. So go out there, read about it, get empowered, look after your bodies, because we are all aiming to be here for the long term, happy, healthy and safe, irrespective of which bits and which organs and which hormones we have left.
Well, thank you on that note. That absolutely does sum it up. Thank you very much, Philippa. That's been fantastic. And I do head to our website to find out more. The Eve Appeal website has a lot of information around these issues. Philippa's mentioned a couple of other sources of information. Do have a look at the NHS website. That does have quite a lot of really useful signposting. And always talk to your GP about these things. If you want to call, ask Eve, our nurse service, and find out more, of course, we're here. And keep the questions coming on social media, and we will do our best to answer those after the programme. So, thank you very much for listening in, and happy World Menopause Day to everybody.